Hi there, my valued, highly treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which you may find useful in your line of duty. Welcome to part 50 of our pharmacotherapy MCQ series majoring on neurology. The first question reads, GOL, a 59-year-old 85-kilo male experiences an NSTEMI and has received 1,650 units of heparin per hour over the past 60 minutes. Suddenly, he begins to complain of very severe headache. According to his primary nurse, who evaluates him, he appears confused. A CT head is done emergently, and it demonstrates an intracranial hemorrhage, what we abbreviate as ICH. So my question to you is, which of the actions listed below would be the next best course of action in Mr. GOL's case? Would you opt to administer protamine sulfate at a dose of 1.65 milligrams intravenously, or would you administer 16.5 milligrams of protamine sulfate intravenously, or would you administer 1.65 milligrams per kilo of protamine sulfate intravenously, and in addition to that administer 10 milligrams of vitamin K intravenously, or would you settle for 10 milligrams of vitamin K intravenously? I'll give you 10 seconds to choose the correct answer. So B would be the correct answer. Choose to administer 16.5 milligrams of protamine sulfate, the antidote for heparin, intravenously. We know that the reversal agent for unfractionated heparin is protamine sulfate. In patients who have received 1 hour or less of unfractionated heparin, we should administer 1 milligram of protamine sulfate for every 100 units of unfractionated heparin. Therefore, Mr. GOL, who has received 1,650 units over 1 hour, should receive 16.5 milligrams of protamine sulfate. Now, I would like to just repeat that 1 milligram of protamine sulfate neutralizes approximately 100 units of heparin. Now, there is a ceiling. The maximum dose of protamine sulfate is usually 50 milligrams. Don't exceed that. It should never be exceeded because of what we call the paradoxical anticoagulation or anticoagulant effect of protamine sulfate when we exceed that dose. We know that protamine is positively charged and it forms an inactive salt with negatively charged unfractionated heparin. Now, heparin has a stronger affinity for protamine sulfate than for antithrombin, and therefore when we introduce protamine sulfate, heparin dissociates itself from antithrombin and binds to protamine sulfate. Now, we know that protamine sulfate binds to both bound and unbound heparin. That makes it an effective antidote. Now, protamine sulfate may be used for low molecular weight heparin overdose. However, since the affinity of the low molecular weight heparins for antithrombin is higher than that of the unfractionated heparin, the reversal tends to be incomplete. That's just a by the way. Let's move to the next question, please. And it reads, which anticonvulsant listed below has a therapeutic reference range of 4 to 12 micrograms per milliliter? Is it Phenytoin, carbamazepine, phenobarbital, or primidone? I'll give you 10 seconds to choose the correct answer. Carbamazepine it is. Now we know that carbamazepine is an anticonvulsant and a mood stabilizer with a recommended therapeutic range of 4 to 12 mics per ml according to literature and even package inserts. The reference range for phenytoin is a phenytoin level of 10 to 20 micrograms per ml, while that of phenobarbital is 10 to 40 mics per ml, and that of primidone is 5 to 12 mics per ml. That's just for your information. Let's move to the next slide, please. And the question reads, Mr. J.K.M, a male patient, presents to your clinic for an INR check and inquires about alternatives to warfarin, which he regularly sees advertised on television. He desires to try one of them since he has difficulties remembering to have his INR monitored and also abhors needles. He doesn't like pricking himself, or being pricked for that matter. He has a past medical history of atrial fibrillation. He has a prosthetic aortic valve that was placed surgically, and he is a depressed patient. So my question to you is, which of the reasons below justifies why Mr. J.K.M shouldn't receive apixaban or any of the other novel anticoagulants? Is it true that novel anticoagulants have shown increased bleeding when compared with warfarin? Or is it true that novel anticoagulants aren't recommended in patients with prosthetic valves? Or is it true that depression is a precaution with novel anticoagulants due to drug-drug interactions? Or is it true that warfarin is preferred for patients diagnosed with atrial fibrillation? I'll give you 10 seconds to choose the correct answer. So, it is a fact that novel oral anticoagulants aren't recommended in patients with prosthetic valves. Now, there may be drug-drug interactions with antidepressants, but this isn't a contraindication to recommending the novel oral anticoagulants such as apixaban, rivaroxaban, dabigatran, or edoxaban in such patients. Now we know that novel oral anticoagulants are FDA approved for non-valvular atrial fibrillation, which is an atrial fibrillation in the absence of rheumatic mitral valve stenosis, a mechanical or a bioprosthetic heart valve, or even a mitral valve repair. Now, I would like to add that dabigatran was compared with or to warfarin in patients with mechanical heart valves, and the trial was stopped, and the major reason was due to increased rates of thromboembolic and bleeding events in the dabigatran group. Therefore, it is contraindicated in such patients. Now, the other agents listed haven't been studied in patients with mechanical prosthetic heart valves. Now, I'd like to underscore that based on guidelines, either warfarin or NOACs can be considered when anticoagulation is necessary for patients with atrial fibrillation. Now, patient-specific factors including compliance, cost, and even convenience to the patient should be considered when evaluating anticoagulation options. Otherwise, patients will not adhere and it would be a waste of money. Now, NOACs shouldn't be used in patients with mechanical prosthetic heart valves due to increased risks of thromboembolism or bleeding, as witnessed in the Bigatron cohort in that study, or due to lack of information supporting their use, as in the case of apixaban, rivaroxaban, and edoxaban. Let's move to the next question, please. And the next question reads, pramipexole, ropinirole, and rotigotine are examples of dopamine agonists which are used as first-line treatment of restless leg syndrome, abbreviated as RLS. Their dose should be slowly titrated, and patients should be closely monitored for side effects and efficacy. So my question to you is, which of the side effects listed below are characteristic of this class of medications? Do they cause orthostatic hypotension, impulse control disorders, somnolence, hallucination, or do they cause all of the above? I'll give you 10 seconds to choose the correct answer. So they cause all of the above. Now, impulse control disorder is a serious side effect that occurs with dopamine agonists. It is important to screen patients for these side effects since it can be associated with risky behavior, for example, excessive gambling, shopping, eating, and even sexual behavior. And these patients may not realize it's due to the dopamine agonist therapy. Now, orthostatic hypotension can occur in up to 53% of patients depending on the agent used. So it's important to educate patients to rise slowly from either lying or sitting positions, especially when their therapy is newly initiated or when their doses are increased or titrated upwards. Now, patients can also experience hallucinations on dopamine agonists. Hallucinations can be auditory, visual, and so on and so forth, and they occur in up to 15% of patients depending on the agent used. Now, I would recommend you use with caution these agents in patients with predispositions to hallucinations or those who have previously had psychiatric diagnosis. This is believed to be dose dependent, so we need to closely monitor these patients, especially with therapy initiation or when we adjust their doses upwards, when the doses are increased. Now, for alternative C, somnolence can occur with dopamine agonists, and it increases the risk of falling asleep during daily activities. It can be very dangerous for a driver, for example, and it's also believed to be dose related and will occur just after the therapy is initiated or when the doses are titrated upwards or increased. Now, I would like to add that dopamine agonists have some unique side effects related to their action on the brain dopamine pathway, which we call the reward pathways. Now, newer dopamine agonists such as pramipexole, ropinirole, and rotigotine have lower incidences of side effects, especially at lower doses that are used in RLS due to high receptor selectivity if you compare them to the older agents, for example. So I would just like to remind you that patient counseling is paramount for managing safe, effective therapy of RLS using this dopamine agonist because of the side effects I've listed there. Let's move to the next slide, please. And the question reads, Mrs. S.O.K., a 79-year-old female with primary intracranial hemorrhage, will require an elective surgical intervention. She has a past medical history of atrial fibrillation, and she currently takes 100 milligrams of metoprolol succinate once daily, alongside 150 milligrams of dabigatran twice a day. The neurosurgeon insists the therapeutic effect of dabigatran must be reversed prior to this elective surgery. So my question to you is, which of the options listed below would be the best course of action in the case of Madam S.O.K.? Would you choose to administer PCC at a dose of 25 units per kilo via IV piggyback, or would you administer idarucizumab at a dose of 5 grams via IV piggyback, or would you use a recombinant factor 7A at a dose of 1 microgram via IV piggyback, or would you administer glucarapidase at a dose of 50 units per kilo via IV piggyback? I'll give you 10 seconds to choose the correct answer. I would opt to administer 5 grams of idarucizumab via IV piggyback. Now we know that idarucizumab is a reversal agent for dabigatran, specifically developed for this purpose. It is recommended for patients with intracranial hemorrhage associated with dabigatran if dabigatran itself was administered within a period of 3 to 5 half-lives, and there is no evidence of renal failure in such a patient, or if there is renal insufficiency leading to continued drug exposure beyond the normal 3 to 5 half-lives. Now, alternative A, the PCC can be used if idarucizumab isn't available. However, the dose that we are given here is wrong. The dose should actually be 50 units per kilo for such cases, so I would not opt for A. Now, alternative C also carries an unacceptably high risk of thrombosis and is no longer recommended first line, so I would not opt for it either. Now, alternative D, glucarapidase is a treatment for methotrexate toxicity. It has nothing to do with dabigatran. Now, the dose of idarucizumab is 5 grams IV administered as 2 doses of 2.5 grams. Now, if monitoring parameters are needed, thrombin time is preferred. Now, thromboelastography or thromboelastometry are also useful. They are mentioned somewhere in literature. Now, the PT or the APTT isn't reliable for therapeutic monitoring of dabigatran or its reversal, so don't use them. It will be a waste of money. Now, in cases of dabigatran overdose, it can be removed via hemodialysis, and I would like to add that it's also reasonable to consider using idarucizumab concomitantly as you dialyze. It's dialyzable. So let's move to the next question, please. And it reads, Mr. E.M.K, a male epileptic patient, is being converted from Phenytoin to Oxcarbazepine. So my question to you is, which of the lab values listed below should be monitored in 14 days time from the time you make that switch? Is it serum creatinine for impaired renal function? Is it serum sodium due to the risk of hypernatremia? Is it serum sodium due to the risk of hyponatremia? Or is it serum potassium due to the risk of hyperkalemia? I'll give you 10 seconds to choose the correct answer. So serum sodium due to the risk of hyponatremia would be the correct answer. Now we know that oxcarbazepine doesn't cause hypernatremia. I'd like to remind you that carbamazepine, oxcarbazepine and escitalopram can all cause hyponatremia, and that happens in 4 to 46% of patients depending on the reference you're quoting. And risk factors include female gender, like this case of ours, age greater than 40, concomitant anti-epileptics or diuretics, and even high serum carbamazepine or oxcarbazepine levels. Now, risk factors to escitalopram-induced hyponatremia aren't known yet. There isn't much experience with it. And just like to add that the mechanism may be due to impaired ability to excrete water through urine dilution. Therefore, sodium and osmolality may decrease. Now, increased antidiuretic hormone, e.g. the syndrome of inappropriate antidiuretic hormone secretion, isn't involved but may occur in rare cases. Now, hyponatremia is chronic while patients continue therapy with these medications, and it quickly resolves after discontinuation of these medications. Now, sodium should be monitored after initiation and after dose changes, and even periodically, to ensure hyponatremia is managed before it becomes severe, where severe means levels of sodium below 125 milliequivalents per liter. I would also like to add that carbamazepine, oxcarbazepine and escitalopram alter water excretion, putting patients at risk for clinically significant hyponatremia. So remember that when you're managing such patients. And this makes it important to check serum sodium, makes it warranted, and this should be done within the first 90 days and preferably even sooner if feasible from the time you initiate any of those 3 drugs. Let's move to the next slide, please. The next question reads, Mrs. J.K.M, a 60-year-old female requiring mechanical ventilation following an admission for community-acquired pneumonia with empyema, status was thoracotomy and decortication. In the course of the morning clinical round, the clinical team notices she is grimacing and restless. He is pulling on the IV lines and the tubes. Currently, she is receiving 2 grams of ceftriaxone infused over 30 minutes once daily, metronidazole at a dose of 500 milligrams infused over an hour thrice a day, propofol at a rate of 40 mics per kilo per minute IV, fentanyl at a dose of 25 mics per hour IV, and famotidine at a dose of 20 milligrams IV twice daily, together with a prophylactic dose of 40 milligrams of enoxaparin administered subcutaneously once a day. Her most recent RAS, where RAS is Richmond Agitation Sedation Scale, score of 1, CPOT score of 5, where CPOT means Critical Care Pain Observation Tool. Then the ICDC-DSC score of 0, where that abbreviation stands for Intensive Care Delirium Screening Checklist. The score there is 0. Some of our pertinent lab values include sodium levels of 135, potassium of 4.2, chloride of 107, bicarb of 24, BUN of 15, serum creatinine of 1.2, WBC of 22.2, hemoglobin of 9.9, and the platelet count is 208. Some of our vitals include a systolic blood pressure of 154 with a diastolic of 99 millimeters of mercury, with a heart rate of 106 and a respiratory rate of 16. So my question to you is, which of the interventions below would you recommend for Madam J.K.M? Would you add quetiapine or Seroquel 50 milligrams via NG tube twice daily, or would you increase her fentanyl infusion to a rate of 50 mics per hour from the previous rate, or would you increase her propofol infusion to 60 mics per kilo per minute, or would you change from propofol to dexmedetomidine and administer it at a dose of 0.4 mics per kilo per hour? I'll give you 10 seconds to choose the correct answer. I would opt to increase the fentanyl infusion to 50 mics per hour. Now, Mrs. J.K.M. has both uncontrolled pain and agitation, as is indicated by the CPOT score, which is greater than 5, and the RASS score, which is 1, which indicates restlessness, along with no signs or symptoms of hemodynamic compromise or metabolic acidosis. That warrants an increase in propofol infusion rates as the best solution for J.K.M.'s status. Now, the 2013 PAD guidelines, what we call the pain, agitation, and delirium guidelines, recommend that uncontrolled pain should be addressed first to avoid deleterious consequences of unmanaged pain. For example, increased delirium, increased myocardial oxygen demand, tachycardia, and so on and so forth. Therefore, increasing the patient's propofol or switching to dexmedetomidine wouldn't be preferred at this time, just because of that clause. Now, the intensive care delirium screening checklist score indicates that our patient here doesn't meet the criteria for delirium. Now, although quetiapine has an FDA approval for use in ICU delirium, no medication has been shown to be effective at improving outcomes in those already diagnosed with ICU delirium. The current PAD guidelines recommend routine evaluation of ICU patients for pain, for agitation, and for delirium using validated assessment tools. Now, the recommended scales to assess pain in non-verbal or sedative patients are, for example, the Behavioral Pain Scale, which is abbreviated as BPS, and the Critical Care Pain Observation Tool, what we abbreviate as CPOT, with scores greater than 3 and equal to or greater than 3 respectively for the two tools, that is, indicating pain. Now, the sedation agitation scale, what we call the SAS, and the Richmond agitation sedation scale, what we abbreviate as RASS, are the preferred sedation scales, with the goal of light sedation in most of these patients. Now, light sedation there would be achieved at a score of 3 on the SAS and at a level of -1 to -2 on the RASS scale. Now, two delirium assessment tools are recommended by guidelines, and these are the confusion assessment method for ICU, what we call the CAM ICU, and the intensive care delirium screening checklist, what is abbreviated as ICDSC. Now, pain should always be managed fast to avoid unnecessary exposure to high doses of sedatives. If you manage your pain well, you do not need to sedate the patients deeply. That's what I'm emphasizing there. Now, I would like to remind you that over or underutilization of opioids and sedatives in the ICU is associated with increased rates of ICU delirium, and it also is associated with prolonged mechanical ventilation. So try to strike a balance to avoid those. Now, IV opioids are preferred over alternative routes of administration for ICU pain management. Remember, the entero or transdermal routes of opioid administration have delayed onset, and these routes may result in, for example, reduced or erratic absorption of the medication, the opioids per se, in especially hemodynamically unstable or in febrile patients. So don't use them in that category of patients if you can avoid them. And I would like to also underscore the fact that titration of sedatives to light levels of sedation and protocolized daily awakening trials have been shown to shorten the time to extubation in this category of ICU patients. That's just a by the way. Let's move to the next slide, please. The next question reads, Mr. R.N.M, a 69-year-old male patient, presents to your hospital with primary intracranial haemorrhage, what we abbreviate as ICH. He has a past medical history of hypertension, atrial fibrillation, type 2 diabetes mellitus, and chronic obstructive pulmonary disease, and he currently takes 25 milligrams of carvedilol orally twice daily alongside 10 milligrams of lisinopril once a day and warfarin 2.5 milligrams orally once daily, and he inhales salbutamol when necessary, pro renata. Some of his pertinent lab results include serum creatinine of 1 and an INR of 6.3, pretty high. He has an ideal body weight of 85 kilos. Some of his vital signs include a heart rate of 110, a systolic blood pressure of 188, and a diastolic blood pressure of 108 millimeters of mercury. He has a body temperature of 98 degrees Fahrenheit with a heart rate of 16. And R.N.M is mechanically ventilated on 60% FiO2. So PCC at a dose of 50 units per kilo is ordered for his intracranial hemorrhage, and the supratherapeutic INR, the value, remember, is 6.3. So my question to you is, which of the recommendations listed below would be the best for Mr. R.N.M now? Would you add recombinant factor 7A at a dose of 1 micrograms to this patient's treatment? Or would you increase the PCC to 100 units per kilo? Or would you add vitamin K at a dose of 10 milligrams via IV piggyback to his treatment? Or would you add DDAVP at a dose of 0.4 micrograms per kilo to his treatment? I'll give you 10 seconds to choose the correct answer. Add vitamin K at a dose of 10 milligrams to his treatment via IV piggyback. Now, the reversal for warfarin is PCC products, and they serve as a means to supplement the coagulation factors 2, 7, 9, and 10 to be specific. Now, while the onset of action is rapid, that is within 30 minutes, the duration of the effect lasts only 6 to 8 hours. And because of this, additional vitamin K is necessary to continue to activate these coagulation factors. Now, conversely, the onset of IV vitamin K is 6 to 8 hours, and the peak effect is approximately 24 hours, if I remember well from literature. Now, additional PCC isn't necessary, so that makes answer B wrong. It's not necessary in this situation, and it may unreasonably just increase the risks of thrombosis, and we don't want to get there in this delicate situation. And alternative A, the recombinant factor 7A also carries an unacceptably high risk of thrombosis and is no longer recommended first line, so I would not opt for A either. Just like to add that alternative D, the DDAVP, is useful, but in the reversal of antiplatelet agents, and it doesn't play a role in reversing vitamin K antagonists like warfarin, so it would have no place in this particular clinical situation. Now, I would like to remind you that for the reversal of warfarin, when administering PCC products, vitamin K should be administered concomitantly. Now, DDAVP can cause profound hypotension and bradycardia if administered too rapidly in the patients who need it. So you have to be very cautious with the infusion rate when using this to reverse the effects of antiplatelet agents. Now, while the onset of vitamin K administered IV is faster than the oral route, their peak effects are roughly the same, approximately 24 hours. Now, IV vitamin K should be administered slowly due to the risk of anaphylactoid reactions that have been reported in literature, and this is due to the excipient which we call polysorbate 80. Just for your information. Let's move to the next slide, please. And the question reads, Lamotrigine is being added to H.K.'s anti-epileptic medication regimen because he experiences breakthrough seizures at his current dose. He also takes Depakote. So my question to you is, which of the following would be the correct dosing scheme and reasoning for this combination for HKB now? Is it Depakote doesn't significantly affect Lamotrigine metabolism, so use standard Lamotrigine titration? Or is it true that Depakote moderately inhibits Lamotrigine metabolism, so fast Lamotrigine titration isn't acceptable? Or is it true that Depakote completely inhibits Lamotrigine metabolism, therefore Depakote shouldn't be used with Lamotrigine? Or is it D, Depakote induces Lamotrigine metabolism, so fast Lamotrigine titration is acceptable? I will give you 10 seconds to choose the correct answer. B is the correct answer. Depakote moderately inhibits Lamotrigine metabolism, therefore fast Lamotrigine titration isn't acceptable. Now we know that Depakote is an enzyme inhibitor, not an inducer. So it can increase the concentrations of concomitantly administered medications such as diazepam, methotrexate, phenobarbital, warfarin, phenytoin, and even Lamotrigine. So you have to be very cautious when administering them. Now, enzyme systems that are affected by this drug include the CYP450 and the P-glycoprotein. Now, Lamotrigine can cause life-threatening rash and even SJS in extreme cases when the blood levels are increased very quickly. e.g. when the dose is titrated too quickly, or when it's concomitantly administered with when the enzyme inhibitors that are usually concomitantly administered with it are suddenly discontinued. So I would like to emphasize that when lamotrigine is added to an additional therapy, that is to Depakote, lamotrigine exposure is increased, and therefore a slow titration, slow not fast, slow titration must be used to prevent those rashes, the SJS, from occurring in such patients. So my highly esteemed viewers and listeners, that brings us to the end of part 50 of our MCQ pharmacotherapy series. If this video benefited you in any way, please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration with me. I look forward to interacting with you in part 51 of our pharmacotherapy MCQ series. Thank you for always being there for me.